Okay, today we are going to talk about chronic disease and sexuality in 3 different perspectives. One is with the focus on multiple sclerosis, the second on diabetes, and the third on rheumatology. That's what was asked to me, to address those 3 different topics. Now let me see. Yeah. I want to take you on a small journey today, and I want to make the trip and do some sightseeing along some of the sexual function, a little bit on the influence of disease on sexuality in general, and then I want to go to 3 hotspots, MS, diabetes, and rheumatology, and then I want to talk a little bit about solutions and maybe about the future of Iceland in sexual medicine. First, on the basics of sexual function. You know, is this male or female? We do as if it's real science with graphs and that kind of things. Is that male or female? I guess you know if you see this one. This is typical, the male, we fall into the black hole. We make a differentiation between desire as the first, excitement, arousal as the second, and orgasm as the third. And if you look into diseases, then you could in fact say that the desire is an endocrine thing, that the arousal is circulation, and that orgasm is mainly nerves and neurotransmitters. So that's a very rough differentiation, but that helps very much when you look into the consequences of diseases. Now, what do you need for sexual desire? For desire is most important that you have testosterone. Testosterone, it's the main fuel for sexual desire. Not only for desire, it's also the fuel for falling in love, and it's fuel to be energetic. Both in the male and in the female, you need testosterone for sexuality. Besides, you need proper balance in your neurotransmitters, and you need sufficient vitality. That means if you are tired, probably you will have less sexual desire. Now, it's not only the man, it's also the woman who has testosterone. Men have a lot of testosterone. They get it 95% from the testicles and 5% from the adrenal glands. In female, it's 50-50. Half comes from the ovaries and half from the adrenal glands. And in women, it starts already very early. You see that part already before you get into puberty. Some of the girls already get testosterone from the adrenal glands during the adrenarche, and that is why about 10% of girls already start masturbating at age 8 or 9 years, which is quite unknown to most people. Here you see for which parts of sexuality you need it. You need testosterone for desire. You need it to get aroused. If you really want to get horny, you need testosterone. That's what goes on in your brain. For women, that's more clear than for men. You need it also to get orgasm. If I had a lot of patients with ovarian cancer who had a very low testosterone, and the most clear clinical sign was having very much difficulty to get orgasm or having no orgasm anymore. And especially for the women who are very used to have an orgasm, then it's very clear that it's a result of the treatment or the disease. You need it also for assertiveness, to push what you want to get it done. You need testosterone for that also. You need it for physical strength. Nearly all doping is testosterone dependent, except the blood dope. And you need it also for mood and well-being. Even some depressions we can treat by testosterone, both in the male and in the female. And of course, if you do a lot with bones and muscles, by testosterone, your bone gets stronger and your muscles get better, and your SHBG, the transport carrier in the blood, goes down when you have more testosterone. Now, what do you need for erection or lubrication? That is mostly circulation. So what you need here is the good vessels, and that is where, of course, nowadays a lot of people with the diabetes, with the lifestyle, what is not very clever, they get too fat, they don't move enough, they have too high cholesterol. That are all reasons to have a bad circulation, and then you get the consequences in erection or lubrication. Erection is in the male, the vessels in the male who take care that you get real strong and hard penis, and in the woman it's in fact exactly the same neurological circulatory things, but there is no capsula around the vessels, and that's why in the women you see that they get wet, where the man gets hard. And the wetness you need it both for reproduction, because spermatic cells, they don't swim in a dry vagina, they only swim in a well-lubricated vagina. And the second reason is you need a lubrication for the mechanical things. If you bring intercourse back to the mechanical basics, it's a cylinder and a piston in the cylinder, and if the cylinder is not lubricated well, the cylinder will burn or you will have pain in intercourse. Now, a big difference between men and women is that for men, the erection is very important because that's our male identity, is very depending on the erection. And for the women, if you don't get wet, you use a little bit saliva or a little bit lubricant. That's not a big deal for women. It's very different in the identity of the person. So you need good circulation. You need the arousability. That's of course the testosterone for that. And you need the good pathways, the neurological pathways to guide the circulation for good erection or lubrication. And then the third one, what do you need for orgasm? Again, it's the nerves and the neurotransmitters. That is most important what we see now, the consequences. That goes wrong mainly in, or for the biggest part of the people with orgasm problems nowadays, they have it as a result of the SSRI antidepressants. That's where you make the changes. I'll come back to that later on. For all the phases, you need those neurotransmitters, and that is a difficult thing because we know in sexology that you damage both desire and erections in some people and orgasm in a lot of people with the SSRI antidepressants, but we tend not to talk about it. GPs, psychiatrists, rehab doctors, oncologists, they just forget to mention the sexual consequences of the SSRI antidepressants. And that is especially for Iceland, I think it's very important. In Iceland, you have among the OECD countries, that is the country, that's a group of wealthy countries where they have good writing down of all the figures of what goes on in society. In Iceland, you have the highest rate of consumption of antidepressants. It's roughly 1 in 10 people who is using antidepressants in Iceland. Now look what happens if you take antidepressants. Here the paroxetine, the citalopram and the venlafaxine are in Holland the mostly used, and they have more than half of the antidepressant use is by these three. I couldn't find the figures for Iceland, but I guess it will probably be the same antidepressants. And you see that a very high percentage of people have problems. Now, desire problems, it's easy, a bit easy to manage that. Arousal problems, that's mainly in the paroxetine, which is can be very troublesome in men. But orgasm, that's a real serious break into the function of sexuality for a lot of people. Half of the people, at least, cannot get an orgasm anymore. That means if you have 1 in 10 Icelandic people using antidepressants, 1 in 20 people cannot have an orgasm. Now, what is the consequence if you cannot have an orgasm? We roughly know that 1 out of 3 says, it's not nice, but anyhow, it's better not to have my depression. 1 out of 3 is confused, and 1 out of 3 is that much confused that they go to stop their medication or take it irregular, which is of course dangerous for your depression, and you get an increased suicide rate also. So we have to address sexuality, because we know also we have tricks how to deal with that.